We're going to go ahead and get started. Thanks so much for joining us this morning. I'm Vincent Atchity, CEO for Mental Health Colorado, and this is our monthly reports and updates with our Colorado partners working to disentangle mental health and criminal justice. Each of these is recorded, and we make the recordings available on our website. And I'm going to share some links over the course of our meeting this morning so that you'll have all these things that I'll be mentioning. So today, the agenda is some updates from me about our work with Mental Health Colorado and the Equitas Project and our Care Not Cuffs effort. I'm going to share some of the things that we've got in the works, and then, as per usual, we'll have a few minutes at the end for other updates from partners as well as questions. I'm going to start off today with some overview of what we anticipate for the coming months of these monthly reports and updates meetings. One of the things that Mental Health Colorado has been doing has been serving as kind of an administrative hub and for dispersing funds from the state's fines committee to projects around the state that are engaged in diversion associated with addressing the competency backlog issue. I'm going to share my screen for a second. Hang on just a second. Find the right spot. There we go. So I'm just going to scroll through quickly. This is an array of the different programs that are currently being funded with Fines Committee funds. To these ends, they each have their own unique approach and set of partners working at this intersection. And what we're going to be bringing together for you over the course of coming months is monthly reports and updates, presentations in the context of this meeting from these programs so that you'll learn a little bit more about them. So I'll just scroll through. We've got funds for the Colorado Coalition for the Homeless, the Denver Competency Diversion Effort, Larimer County's Competency Docket, Aurora Municipal Courts Diversion Project, Mesa County, pretrial, community-based enhanced restoration. Summit Stone has a competency hub, the Mile High Behavioral Health Care, Impact Integrated Insight Therapy, DU's first program, the Denver Sheriff's Department, Peak View, Denver Health, Colorado Mental Health Institute, Boulder County Justice Services, Gateway to Success Day Reporting Center, the Ananeo Competency Housing, Embark Housing and Day Reporting Center, and then Colorado Mental Health Colorado is getting a fee to administrate this work. One of the things that we're going to be most interested in doing in coming months is beginning to see some consistent data collection coming back from each of these programs so that progress toward addressing the competency diversion program is, we're able to assess that. Another thing that we're very curious about, and we'll be interested in hearing your thoughts about, given our perspective as the population health advocates, obviously we're very interested in the competency diversion projects and the competency backlog, but from a public health and population health perspective, this is just, one of the state's critical pain points when it comes to behavioral health. What we're really interested in is that health across the lifespan for all Coloradans, and very curious to know more data as it becomes available about the population that is caught up in the competency system. What we would like to know more and more about as we go forward is the extent to which these individuals are living with conditions and needs that may have been identifiable and potentially could have been met much earlier along in their experience of living with these conditions, even into youth and early childhood. We're interested in understanding adverse childhood experiences and adverse social determinants of health, local barriers to care and supports that may have made these individuals more vulnerable to forensic involvement. All of that kind of information about these populations is something that we would like to see going forward, and hear from all of you as well, so that we can, in our advocacy, continue to point to how to close gaps and overcome barriers, so that what we're doing is promoting greater human thriving across the board for Coloradans of all ages. So some of that's the Fines Committee work. I wanted to take a moment to mention Lynn Unger, who has joined us and is now working with Mental Health Colorado as the Competency Diversion Projects Director. And Lynn's on there too. And Lynn is bringing together the programmatic presenters from the different funded programs, and is also, her role is to be scanning the landscape to identify other good prospective efforts for achieving these essential goals of reducing that competency backlog finally, and getting people in better access to the care they need. So thank you, Lynn, for joining us. We'll be hearing more from you in coming weeks. I'll move on to my next topic, which is just to mention, if I hadn't mentioned it before, the work of our partners in a work group that's been led by Judge Steve Leifman of Miami-Dade County. We've had this group of forensic mental health legal experts convening for the course of the past 3 years or so to re-examine civil commitment laws nationwide and make recommendations around broader pathways to civil commitment for individuals who may be at greater risk of forensic involvement, in order to improve their outcomes and reduce this reliance upon the justice system. That group completed its work, and I will share a link to that document. I can share my screen for a moment so that you know what I'm talking about. Just a second here. So this was the model legal processes to support clinical intervention for persons for serious mental illnesses. And it's got a second section of the document, which is the pathways to care, a roadmap for coordinating criminal justice, mental health care, and civil court systems. And that is a pathway really mapped based on the work that Judge Leifman and his colleagues in Miami-Dade have done over the course of the past 15 years or so. And one of the useful at a glance features of this document is a decision tree for folks in the justice system working with individuals with behavioral health needs to promote that kind of diversion pathway. And just also to mention that this document was produced in partnership with folks at the National Center for State Courts and endorsed in August by the Conference of Chief Justices and the Conference of State Court Administrators National Judicial Task Force to examine state courts' response to mental illness. And our hope and expectation is that judicial leaders around the country will use this as a framework for discussing their local community health needs and pathways to addressing them differently. And I'll stop sharing. And I see Brian. Hey, Brian. Brian's got his hand up.
Hey, Vincent. Thank you. And this is regarding the first topic that you were speaking to on the Fines Committee.
Yeah.
I was just curious, and maybe this is a question for Lynn. Looking at the list of grantees so far, I wasn't familiar with 100%, but I recognized a lot of them, and a lot of representation in kind of the urban centers statewide. I don't think that we've got a good, speaking on behalf of our rural part of the state, a good sense of this opportunity. Is it available statewide? Is it something we can apply to, or where can we get some more information about that?
Brian, I hope that you will email me. I've been working to really get to know and contact jurisdictions outside of the Front Range into the more rural and frontier areas because there is the need for that. And so I'd be happy to connect with you. I know you all work in Lake, Custer, Fremont counties. And so I think it would be great to connect with you and talk about some of the needs that you're seeing in your community and see if we can explore some ways to connect to the right folks and maybe get a conversation started.
Great, thank you, Lynn. Brian, I hope that answers your question. Good. I could also just clarify, maybe not everybody is entirely familiar with the Fines Committee. The Fines Committee consists of, this is associated with the federal consent decree, and the Fines Committee consists of representation from both plaintiff and defendant in that decree, as well as the special masters. And they are the decision makers with regard to funding allocation. We don't have any role to play in that. Lynn will be making recommendations and based on her research, and the Fines Committee makes all the decisions. All right, let me just continue with a couple of other things I wanted to mention to you today, and that is some updates about the work of Colorado's first Jail Standards Commission. I've been serving on the commission since it started meeting, and I just wanted to put a link in the chat so that you all have access to the work in progress. This committee is making recommendations for jail standards across the whole gamut of operations. And so far, the commission has divided into subgroups to work on a variety of different operational areas, and has been, as these subgroups come up with their sets of recommendations on a variety of different topics, they bring them to the full commission for approval of draft form. And all of this is underway and it's all publicly available. The commission meets publicly, as do all of the subgroups, and the materials they're producing are all also available. And commentary from other folks across the system is very welcome. The commission is doing its best to hear from all folks who have something to contribute on this front. So it's an exciting opportunity, and there will be more to come about that as it begins to materialize. I thought that it was particularly auspicious that the first set of draft recommendations associated with jail standards was around health and healthcare access in jails. And that seemed like, from my health advocate perspective, exactly the right thing to begin with. And I'm seeing a question from Deborah. Is anyone working on requiring behavioral health improvement measures through programming and treatment while a person is incarcerated? That's a great question. The commission itself is making recommendations about access to care while incarcerated, but the commission is not so far designated anyone to work specifically on that, on the improvement measures. some of the folks on the call maybe. And then as far as progress goes, we've made recommendations so far about healthcare access, the housing and programming requirements, staffing requirements, and a variety of other topics which are still works in progress. And the commission has largely been unanimous or nearly unanimous in approving draft recommendations so far after much discussion of each set of recommendations. All right. The next thing I just wanted to mention is ongoing work of a prosecution research network that we've been hosting. That group has now acquired some funding from the Arnold Foundation to work with a subset of involved prosecutors on data gathering around the clients that they're serving, so that there is some greater consistency of measures around from one program, from one prosecutorial office to another, so that learning and progress can be accelerated that way. Let me just share one more site with you. We've got this is the Care Not Cuffs page on the Mental Health Colorado website, where we've got a variety of different things available for you. This is the page for these monthly reports and updates meetings, which you can see here. Recordings are available of each of them, so that this is a resource. I'll stick this link in the chat in a moment. We'll be hearing from folks who've been operating the SAFER program, which is a program here in Arapahoe County that Mental Health Colorado has been supporting, which is providing shelter for individuals who have forensic involvement and yet do not need to be kept in jail. And so this is had some COVID relief funding over the course of the past couple of years, and we're beginning to have enough data to share about that work. You can also find on this page the various course corrections documents that Equitas and Mental Health Colorado have supported the creation of over the course of the past several years. Those are interesting to refer to just for the sake of seeing the emerging consistency of recommendation across sectors and communities as we more consistently work toward disentangling mental health and criminal justice. And then there's our model legal processes document as well. So I will put that in the chat. And then that is really it for my criminal justice summary. I can have some questions about that. And then if we have a few minutes left, I will share some summary of our policy agenda for 2023, in case you're interested in that as well. Yeah, thanks, Mark. I will share the link to all these things before we end the call. I just have to not do it simultaneously. All right, let me just see if I can find handily our policy brief. I can stick that in there as well. What we've been saying at Mental Health Colorado is that we are interested in promoting healthier minds across the lifespan for all Coloradan, and have been trying to be very consistent in hitting the beats of that lifespan in our communications. We're talking about birth to death, and how mental health is a key aspect of our existences from one end to another, and that there's a whole variety of different policy areas that come into play in supporting that greater quality of life. So we begin with talking about a strong start for all children, and support for families as always the number one area to focus on when we're interested in promoting greater population health outcomes. And then all the way to wellness and well-being in aging, which is an increasing concern for us as our aging population gets significantly larger over coming years, and how unfortunately we have so little structured in our communities nationally to support well-being and aging, and so many age into economic insecurity, housing insecurity, loneliness, isolation, unstable access to care, a whole variety of things. And that's, to my mind, one of the most lamentable features of our community well-being, is that for all of our resources and intelligence, we haven't been able to achieve that really meaningful sense of true social security for more Coloradans and more Americans across the board. So that's our scope of things. In this particular year, we're not, unlike in past years, not doing anything very dramatic in terms of tinkering with behavioral health care systems. We've had a number of significant pieces of legislation passed in the last year or two, and are now involved in supporting the implementation of the Behavioral Health Administration, and watching that closely, and keeping an eye on our people, the experience of people who are consumers of the system, and are watching and waiting before making further adjustments on that front. What we are doing is, again, focusing on that upfront acknowledgement that getting people off on the right foot as young people is a key intervention area. And one of the pieces of legislation that we're bringing forward is based on a California expansion of Medicaid behavioral health care accessibility to young people, based on their experience of a whole variety of adverse social determinants of health, so that young people who have experienced things like having an incarcerated parent, or a deceased parent, or having experienced homelessness, or a whole wide variety of adverse childhood experiences, can access Medicaid reimbursed behavioral health care without the necessary prerequisite of a diagnosis. So we're hoping that that will broaden the, on the one hand, broaden the pathway to care, but then also broaden our shared cultural fluency about how adverse social determinants of health do indeed make us more vulnerable to mental health and behavioral health conditions that can negatively affect our outcomes, and promote that greater understanding of how these things need to be taken seriously and addressed as early on as possible. Another piece of legislation that we're working on this year that affects young people significantly, although it's not absolutely not limited to youth of Colorado, is around access to care and quality of care associated with eating disorders. Eating disorders are one of the most deadly of mental health conditions, and there has been relatively little regulation of access to care for eating disorders. We're addressing that in this bill, which will improve some standards of care expectations, as well as do things like limit the use of body mass index as the determining factor for medical necessity for reimbursement, as BMI has been somewhat discredited with regard to how it accurately reflects someone's actual need for care. And then the bill will also limit the sale of diet pills, over-the-counter diet pills, or to minors without a prescription, as that is a known gateway to exacerbated eating disorder. So there's that. We're also doing some work in partnership with Disability Law Colorado on legislation associated with the use of 4-point restraints in the Department of Corrections in order to improve some mental health care, access to care in those settings. There's a number of other things of potentially less interest to this particular group. We will be hosting our Legislative Education and Advocacy Day in March, and I'll share some information out with that in a follow-up email and encourage you all to participate in that as well. All right, that's it for me. Any questions for me or any updates from any other partners?
I think there are a couple of questions in the chat. Oh, I see. Lynn just answered it.
Yeah. Anybody?
I have some questions, if that's okay, Vincent.
Sure, go right ahead. Thanks, Mom.
I guess the first one, and I'd like to read that paper, but what are we looking at for facilities for civil commitment? Because right now it feels like we have attempted to do some civil commitments in our county, and there is no place that we can send anybody.
Yeah, great question. And exactly my question. You know, as I mentioned, we've been supporting the work of this work group on these laws. And my feeling is that, you know, it's a pretty easy, comparatively easy matter to go in there and change a law. But it is not helpful to change a law if there is not a reality in place to implement that law. And so that's exactly my concern, is that, and as an advocate, I'm prepared to concede that there is, you know, I'm ready to argue that there is a place for a lower bar to involuntary care for certain individuals whose needs are great and unacknowledged. And that kind of involuntary care, with an emphasis on that word care, as greatly preferable to the current process of not caring and instead criminalizing and just allowing our justice system to fulfill that role of community care provider. So preferable to that. But I strongly believe that before getting to a place where any kind of involuntary care ought ever to be imposed on someone, there ought to be very substantial effort to engage someone in voluntary care with meaningful mobile outreach that is persistent and compassionate and patient. And we don't have that consistently. And, you know, before you would need to, you know, take someone into the community's custody for a care that doesn't exist voluntarily, that's a pretty hard, it's a pretty high bar. It seems like the quality of care has to exist voluntarily before a responsible community does more involuntary care. And it doesn't. It doesn't care in terms of that effort to engage, and it definitely doesn't exist in terms of that capacity to provide a range of supports from assertive outpatient to short-term, mid-term, long-term inpatient care and supportive housing. We don't have those mechanisms in place in most places. And so my feeling about this document is that it's an opportunity for judicial partners who recognize that it is desirable to have a system of healthcare as opposed to a de facto forensic system of care, to use their position as judicial leadership to convene local partners to stage these conversations and try and create more local momentum toward creating the capacity for that civil system of care. So it's a potent set of recommendations that needs to be a seed for conversation rather than yield a full-blown result.
Yeah, we're running into a lot of different issues with that. The other thing I just wanted to ask about is, you said you were looking at adding, Medicaid or Medicare to people without a diagnosis, if they have those outside liar factors. What I know we're running into with our community mental health facility in our county is the wait list to get in. We're looking at 2 months, 3 months before they can get in to see a provider or to see a clinician. Is there going to be, I guess, more of an incentive for community mental health to broaden their spectrum with clinicians and providers, or how is that going to work? Because I could see where all of a sudden we're allowing more people to get care. We just don't have the system set up to provide that care, even right now. And if you're going to tack on more, because I know in our area, and I think throughout all the United States, we're running into a deficit of clinicians able to work in community mental health settings or hospitals or correctional institutes. And, even our county here, our mental health is run from a private company. And, we've been trying to hire for the last 2 years clinicians to come in. And I know our community mental health, they're short-staffed, and I know there are local emergency room hospitals and things like that are short-staffed on clinicians. Is there going to be, I guess, if we're going to expand the service range, is there going to be more of a financial avenue for them to be hiring people?
Yeah, another good question. And it makes me think of a remark to make about the 988 number as well. And my understanding is that, I'm totally aware of those access issues presently and had indeed been thinking about how this may exacerbate those waiting lists. My hope and understanding from some of the co-advocacy partners is that the restructuring of the criteria for reimbursement by Medicaid may offer opportunity for some expanded workforce there. But, it may have a short-term adverse effect of more greatly impacting that access issue. And on that note, that's similar to my mind to the 988 rollout. It's been my understanding that 988 implementation nationwide varies from community to community, and that one of the concerns of crisis service providers in the different states is that additional volume of demand based on the greater accessibility of a number that's memorable. And so many of the partners in states have not rushed to market the number. There's not been an enormous investment in communications around 988 as the respondents gear up in order to handle increased capacity. And so it's sort of like acknowledging that the need is there is a valid thing to do, because as we are adjusting the scope and size of a system, it's important for us to know what the volume of need really is, rather than having a sort of artificially or blindered view of what the volume of need is. I've always been surprised here in Colorado that there's not been more widespread marketing of crisis services. And my understanding is that to some extent it's been out of concern for volume and demand. And that just, there's something ironic about that in a dark kind of way. So.
Vincent, thinking about that, I appreciate you acknowledging the workforce challenge, and that it's very easy to identify and think up great programs, but if there's nobody to operate those programs, then you're not really getting anywhere and moving the needle. A very tangible way that I think support can be demonstrated in the upcoming legislative session is to support things like provider rate increases for those who accept Medicaid or who are contracting with the Behavioral Health Administration. So that's not a mental health centers versus any other kind of provider. It's, are you serving safety net population or not? We do not have enough resources to meet the expectations and the demand, not only the expectations programmatically, but certainly not the demands at the local level. I think that's a statewide problem. If we can at least try to keep those community-based providers on par with the, for example, increases that go to state government employees, I think that that would be in small part a huge help to make sure that we can stay competitive, to bring in workforce to do what is tremendously challenging work, especially when you start to talk about the crisis system and working with folks who are at that intersection with criminal justice system. So I think that needs to be a shared priority across the board. Unfortunately, I think most of the conversation in recent years has been around how do we bring in third-party intermediaries to manage the system, which my guess will be large for-profit commercial insurance companies, as well as how do we put downward pressure on the provider rates for the people who are doing community-based work. That takes us in the wrong direction, in my opinion, and I hope that we can get behind something that really advocates for the need for more resources at the point of care.
Yep, thank you so much, Brian. Makes sense to me. It reminds me of another couple of things I should have mentioned, and if I didn't in a past meeting, and that's that the RFPs are out from those ARPA dollars, those American Rescue Plan Act dollars that came out of the Behavioral Health Transformational Task Force. And one of them is something $80 million plus for behavioral health workforce development proposals. So that's out now. And then the other one that may be relevant to this group is the Community Gap Grant program, which is expecting to elicit applications from community partnerships around the state that are able to identify a specific gap or series of gaps for a specific population, particularly folks who are vulnerable to justice involvement, and propose some way of using these dollars to close that gap. So I will make sure in a follow-up email to include links to those RFPs as well, because it seems like much of the work that you all do would put you in a good position to be part of one of those community partnerships seeking that funding. Does anybody on the call already engaged in crafting a proposal for one or another of those, Ryan?
Yeah, absolutely. Funding for co-responder programs, funding for crisis programs, school-based programs. I think the issue is actually almost like there's too many grants coming out at once. It's a little bit difficult to, I think, for the communities to navigate. And then being really thoughtful about taking on a grant program, building capacity to do something only if we know that there's a way to sustain that program after this one-time infusion of federal dollars goes away. That could be kind of a really devastating blow to communities if we're building things based off of that short-term grant funding and we don't have the Medicaid or the other resources coming in on the back end to sustain it. So it's a huge opportunity and one that I think we need to be really thoughtful about.
Yeah, thanks for mentioning that, Brian. You know, and the other thing I want to mention, Lieutenant Gutzweiler's on the call, and I was just referring to the slide that he used when he made his presentation about the Summit County co-responder, where he took the trouble to enumerate the cost differential between mental health crisis intervention done the old-fashioned way, to put it so to speak, versus done with their co-responder team, and how there was something like a $34,000 per incident disparity in those two approaches. And that's been like a persistent theme for my thinking that I'll just keep reiterating, and that is, can't communities come together and begin to perceive the extent to which these innovations, which you could kickstart with this investment between now and 2026, could be backfilled for ongoing funding by the savings accrued to other operational areas by just doing things differently. And that would require, you know, cross-departmental budget flow or something like that. And maybe I'm just too naive to see how impossible that is, but I like to think that the money is there. It just needs to be pushed in this other way instead of being used in the way it's currently being used. And I see, Lieutenant, you're on. You have any further observation to make about that?
No, I think it's kind of labor intensive on the agency side for us to, you know, put that all together, but it also is beneficial whenever you're trying to illustrate this to the lay person that may not deal in these kind of crisis responses every day. Whenever they see that those hard numbers, it's found funding for us in a number of avenues and weird bedfellows and partnerships in our community, to a point where we have been able to fund an entire program piecemeal, part by part, by going hat in hand to a number of people, and really building that system out. Hey, this is the savings you accrue each time we're able to do a stabilization in place. Is there a part or piece that you could contribute to our overall program? And I think we have a patchwork currently of around 12 grants, and community partnerships, tax initiatives. It took a lot of parts and pieces to put that together, but yeah, I see a lot of value in each community kind of putting those numbers together and just having them in your back pocket for the right time whenever you can present those. And sometimes it really pays off in spades.
Noticing just now that we've just gone over time and our commitment was to keep these meetings short, 45 minutes. We will follow up with some of the things I mentioned and hope to see you here again next month. Take care.